I'm Dean Kereiakes, chairman of the Christ Hospital Heart and Vascular Institute, professor of medicine at the University of Cincinnati, and clinical professor of medicine at The Ohio State University. I'm also deputy editor of SCAI, and I'm here today with Margaret McEntegart, who from New York Presbyterian Hospital, Columbia University, Irving Medical Center. Also, Suzanne Baron, who is the Director of Interventional Cardiology Research at Mass General Hospital in Boston, also Deputy Editor of SCAI. Robert Riley, Chief of Interventional Cardiology and Director of both the Complex Coronary Artery and Mechanical Cardiac Support programs at Overlake Medical Center in Bellevue, Washington. We're here today to discuss a manuscript, a very important manuscript, published in SCAI entitled Equity of Modifying Plaque of Women with Undertreated Calcified Coronary Artery Disease, the Design and Rationale of the EMPOWER CAD study. You know, in reflecting on this topic, I was reminded of a quote from Marcia Angel, who is an internist and pathologist, and also the first woman editor of the editor-in-chief of the New England Journal of Medicine. She once said that all women are preoccupied with breast cancer. They are 7 times more likely to die of atherosclerotic cardiovascular disease. Now, ASCVD is the #1 cause of death in women, and yet women are underrepresented in clinical research trials of novel innovative therapies. Tell me, Margaret, tell us, Margaret, about the EMPOWER CAD trial, which is specifically designed for women.
Thanks, Dean, and thanks, Guy, for the opportunity to tell you about the EMPOWER CAD study. So just a bit of a background to follow on from what Dean said about why we arrived at this clinical trial. So we know from data from the WIN-DS collaboration that female gender is an independent predictor of adverse events after PCI to calcified lesions. We also know from registry data, and the graph on the right here is a registry we performed in Glasgow when I previously worked there, that women are particularly susceptible to complications when performing atherectomy. But reassuringly, when we looked at the pooled analysis from the Disrupt CAD 1 to 4 trials, we saw that procedural success and 30-day MACE rates were similar in women and in men with IVL. And importantly also that with procedural complications, which were very low throughout the entire cohort, this was sustained in women and in men, unlike the data we have from the atherectomy registries showing women had significantly higher rates of complications. But it's important to note, as Dean already mentioned, that the number of patients in the trials that were women was quite low, so 144 women versus 484 men. So the paper, the Disrupt CAD pooled analysis, 6 specific outcome analysis was published in SCAI, as Dean mentioned, and then the findings of that went on to be incorporated in the SCAI expert consensus statement on 6 specific considerations in myocardial revascularization, with this kind of hypothesis that maybe what we're seeing here is that IVL is a safer way to deal with calcium in women than other methods of treating calcium. But obviously the data remained somewhat limited. So this really motivated us to go forward and try and kind of gather more data in the female population and the EMPOWER study. And the objective of the trial was to determine whether these results showing similar safety outcomes across both sexes could be replicated in a larger real-world population of female patients with severely calcified coronary lesions. So just to tell you a little bit about the design of the study, so you were able to use the Shockwave IVL system, either the C2 or the newer C2 Plus with more pulses. This was a prospective multicenter single-arm observational study. Target was to recruit 400 patients at up to 50 sites in the US and in Europe. Follow-up planned at 30 days, 1, 2, and 3 years. The study population, all female patients, with planned PCI with an intention to use IVL and then proceed to stenting as standard of care. Very importantly, we wanted the exclusion criteria to be minimal. So the only 2 things that would exclude a patient was if they had in-stent restenosis or presented in cardiogenic shock. You're allowed to treat multiple lesions. You're allowed to use all the adjunctive devices and technologies, either pre or post IVL as required. But the idea was to use an IVL first strategy. So if you could use IVL as your first device and it was effective, stick with that as a plan, but with the options to do what you needed to do clinically to get the case done successfully. The primary safety endpoint, target lesion failure at 30 days, primary effectiveness endpoint, procedural success. And there was a planned OCT sub-study. There's a whole series of secondary endpoints that I won't labour for the purposes of this discussion, and various planned subgroup analysis, which we can go on and discuss a bit later at the end, including time points and detailed analysis of the morphology and severity of the calcium, looking at strategies of whether that device was used before IVL, after IVL, etc. And this was a kind of treatment algorithm, the IVL first treatment algorithm. So essentially planned PCI with IVL, patient met the inclusion criteria for the trial. We encouraged pre-IVL imaging, pre-dilatation, and then once the decision was made to proceed with IVL therapy, the patient was included in the study. If the IVL crossed, it was used for treatment. We then encouraged re-imaging of the lesion, and when the operator felt they had adequately treated the plaque, to go on and stent and post-dilate and perform a final imaging run. If the IVL would cross, you could then switch to using any of the adjunctive devices that you felt you needed to prepare the lesion to then deliver the IVL. If after the other device you felt you didn't need the IVL anymore, you didn't necessarily have to use it, but you could circle back and then use it after another device. So we really wanted this to be as real world as possible. So as mentioned earlier, the study design paper was recently published in SCAI in October. So just to tell you a little bit about enrollment. So we had planned that enrollment would complete in March 2025. We're absolutely delighted to complete enrollment in October, almost 6 months ahead of schedule. We ultimately ended up with 48 sites, 2/3 in the US and 1/3 outside of the US. One of the other really important things about this trial was we also wanted to use it as a platform to encourage more female investigators to get involved in clinical trial work. So ultimately, 71% of our PIs were women, a lot of them early career female interventional cardiologists keen to get involved in the academic space. We're really proud of that. So I'm going to leave it there and open up to you guys for further discussion and consideration. Thanks.
That was excellent, Margaret. Thank you very much. I might throw it out to you initially. In CAD3, we had 100% severe coronary artery calcification. That it's either 15 millimeters on both sides of the vessel and inclusive of the target lesion, or a 270-degree arc by intravascular imaging. Can you tell us what percentage of these women who were enrolled, 400 women, that had severe coronary artery calcification, core lab adjudicated?
Yeah, so Dean, we used the same inclusion criteria as you did in the Disrupt trials. So either angiographic or imaging based inclusion criteria. We obviously will have the core lab data to validate that once all that analysis has been performed. One of the really interesting things that we've observed from kind of an early look at the patients in the trials is the mean age of the patients is significantly older than any previous trial in this space. There's a significant proportion of left main disease and a significant proportion of patients who had other adjunctive devices used. So we think that we've captured a really highly comorbid, severe calcium population, just having an early look at the data. So I think we have achieved our goal of a proper real world patient population. And I think that's important because I think one of the weaknesses sometimes of trials in the complex PCI space is that we end up being, because of the kind of rigorous inclusion-exclusion criteria, we end up including patients at the lower end of the risk, and then we're not sure how that data then applies to patients at the higher end of the risk spectrum. I'm hoping what we're going to see in this cohort of patients is that we've managed to really recruit a high-risk, severe calcium population.
Excellent. I may throw this out as a jump ball for whoever wants to chime in, and that is, should we expect that there's a difference in calcium distribution in women versus men, even in our pooled analysis of CAD 1 through 4, OCT sub-studies. There are very few women relatively. And nodular calcium, is there a frequency difference, difference in distribution? What do you expect?
All right, I guess I'll take this. So, one of the, and then Suzanne, you're gonna wrap this up after I bungle it. So, one of the interesting things is what, we know is that women have more calcified lesions compared to the male counterparts. And so a study like this where, CAD 3 was really for regulatory approval, right? Get the device to market. Now we've got to decide, how does it affect different populations? How do we use it? How do we optimize its use patterns? And, one of the ways is that it seems to really close that gap in care between men and women with severely calcified lesions. And that is one of the first times we've seen that, at least, in the time that I've been practicing. We really haven't seen anything close that gap. And so we all looked, a bunch of people looked at that and said, hey, we need to look at this a little bit more, right? Because it was really a retrospective sub-study analysis, not pre-planned, or at least I don't remember if it was pre-planned, but I think maybe it was pre-planned. But regardless, that's hypothesis generating. So then we take that data and say, how do we formally test that? And so I think what'll be really interesting is what the preponderance of calcium is in this population. Just as you said, Dean, they did loosen up the criteria to be moderate to severe calcium in this compared to just severe with CAD 3. It's going to be really, and I think that that's really important because we know that what we see angiographically doesn't always correlate with what we see with intravascular imaging, and that is key. We'll often look at a vessel and say, I'm probably fine, right? I just get down, I use a NC balloon, whatever. You take the IVUS down, you say, oh my goodness, that is a huge nodule. That's a really big concentric thick ring. That's a really eccentric thick ring. And so we don't always know. And so I think broadening those criteria so that we can really look at where IVL is truly used, right? It's not just in these railroad tracks, both sides, oh my gosh, am I gonna have to road our IVL? It's all these other patients. And so with EMPOWER, being able to really liberalize that inclusion criteria, I think is gonna be key. And I think we're gonna learn a lot about what it means to have angiographically moderate to severe calcium and how does that correlate with our intravascular imaging findings. And that's why the use of OCT will be really clutch compared to IVUS. IVUS shows us a lot. OCT from a clinical trial study standpoint gives us a bit more in terms of knowledge generation. And so really, really excited to see what those patterns are, what those distributions are. Because right now, I think we still just have small data points based on small subset analyses. And I think what we're going to see here is some really formal definition of what the patterns look like and how they're treated.
Just jumping in on that too, I think the other thing with the inclusion criteria being so broad is that we have, as you alluded to, Margaret, is we're going to have an incredibly real world population. And the reality is that a lot of women who present with coronary disease, particularly calcified coronary disease, present older, they're frailer, they're presenting more acutely in some ways. So those patients are often not included in these studies. And so we really are going to get to see the patients who might benefit. I think what we've seen a lot is we know there may be a higher rate of complications with these women when they're presenting with atherectomy, and that makes sense, right? Again, older, frailer, smaller vessels, higher nodular calcification. Is this an alternative that we can use to treat these women, especially since I think that prior to this, some of these women just weren't being treated. They were getting medical management. And this will actually be able to give us some answers as to whether or not this is a good, safe modality to treat folks who may or may not have been treated in the past.
Margaret, older, more calcium. Do they also have an increased prevalence or incidence of diabetes and chronic kidney disease, GFR under 60 in this population compared to what we published in CAD studies?
Yeah, it does look like that, Dean, and it was quite interesting because when we originally funded the OCT sub-study, we had hoped that we would get as much as 50% of the population on the OCT sub-study, so they funded us up to 200 patients, but we only actually managed to get 115 ultimately, and when the main reason people cited for not including the patient was concerns about CKD, the patient's comorbidities, complexity of disease, the need for multiple runs, etc., that obviously lends itself more to IVUS. So it's quite interesting. There's lots of signals in the study of the complexity of the patients that were treated and the comorbid conditions they presented us with, or LV dysfunction, etc. So It's going to be really interesting. It's going to be very exciting if we see, a lower complication rate than we might anticipate in this kind of comorbid high-risk group. That's going to be really exciting, I think, because really prove that the device is improving safety for the female patients.
Do you plan an analysis that's stratified by the severity of calcium as either determined by maximum arc or calcium volume score? Okay. And the reason I say that is in CAD, we didn't see the other CAD studies a difference in optimization of stent, whether it's MSA or percent expansion, based on calcium angle, whether it was less than 180 or 360.
Yeah, we are, Dean. We're going to do that same analysis. And I think that's super interesting. And one of the things I'm particularly interested in is the whole nodular population, So we've obviously seen from the disrupt analysis that it looks like IVL works in nodules. I'm keen to see if that's reinforced with the data from this trial, because obviously for most of us, that's a very difficult aspect of calcium management, dealing with the thick, eccentric, or the nodular. So it's going to be really interesting to see if that's borne out here, because if it is, then it provides us further reassurance that it definitely is an efficacious treatment for that type of morphology.
That's really excellent. I look forward to that. You're going to capture whether atherectomy prior to IVL, although you recommend IVL first. And there's no other data set in my mind that does that. All of the other quote registries like ACC, NCDR, we have no idea what adjunctive technology was used either prior to or following IVL. So when you see something like a perforation, you're not sure what did what. Can you comment on that and whether that will be analyzed at the end of the study as well, the sequence?
Yeah, so actually when we were designing the trial, initially the company were keen for us to screen patients out that had lesions, uncrossable lesions. Yeah, so they wanted a clean data, and we persuaded them not to do that. We said, this is a really rich group of patients to capture, the ones that have to go to atherectomy first, and then either get IVL or don't. So we kind of persuaded them that they were kind of contributing to the knowledge base of the field by not screening those patients out. So that was a kind of evolved aspect of the protocol to allow us to do that, and also then to allow us to encourage people to go on and use other devices afterwards. So I agree. I think the whole combination therapy part of managing calcium is under investigated, and I think this is going to provide some interesting data. And as you say, we'll be able to capture exactly when the complications occurred during the cases, and therefore maybe attribute it to the sequence or a specific device. I mean, the other data that's going to be coming is Suzanne's trial, obviously, the shortcut trial with IVL versus cut and balloon plus or minus rotational atherectomy up front. That's also going to be an interesting data set to follow on from this one to provide a very valuable evidence around combination therapy.
But I actually wanted to say, I think it's really great that you did include combination therapy. And we know from Prepare Calc Combo that there may be a benefit to combination therapy. And I think, at least anecdotally, we're seeing that used more and more and more, where folks are needing more than one modality. And so to really be able to capture this, and again, particularly in women who, the reality is, generally make up 25% of a study population. You have 400 patients. This is an incredibly rich data set, and I really congratulate you and the study leadership for making this such a broad and really just frankly useful and applicable trial to all of our patients.
It's tremendous to have both of those studies be able to do that. You're all familiar with the Frampton paper published last year in SCAI that looked at a much smaller population of women, but suggested that both MACE and TLF at 1 year was actually numerically less than in men. There were only 106 women in that, but this is a 30-day primary endpoint, just like the other CAD studies. I'm really fascinated to see what the clinical event rate to 1 year is. And see how that comes out. Any comments?
Yeah, agreed. And I suspect, it's always difficult, isn't it? Because I kind of have a local perspective on the cases we put in, and then you have a kind of trial perspective. But I'm anticipating from how things look, we're going to have a pretty high event rate at 1 year, just from the kind of comorbidity of the patients. So yeah, I think we're going to have a lot of data to look at, and lots of ongoing analysis and learning as time passes through the trial follow-up.
Good. Any other comments? Suzanne, Robert?
Yeah, so one of the things that I just wanted to bring up was this idea about combination therapy, and I still think there's so much to learn. When we look at the outcomes from IVL alone, Disrupt CAD, the pooled analysis, things like that, and we compare it with like the ROTA-SHOCK registry or the ROTA-SHOCK trial, we see that adding ROTA to IVL in all comers doesn't really change outcomes in terms of just stent analytics, whether it be MSA, things like that. We do see a higher numerical incidence of major adverse events. So I think a lot of that was driven initially by remuneration issues with IVL prior to reimbursement. And so a lot of people were using rotational atherectomy to sort of get the ball over the line in terms of making things work from a financial standpoint. And then the question was, well, was this a strategy that actually helps? And what we're seeing is that it doesn't necessarily help. The question in my mind is, okay, so we know that just doing ROTA and then IVL probably doesn't buy me much. But what about where IVL won't pass, which is exactly what EMPOWER is designed to evaluate. So okay, I got an IVL first strategy, but man, I just can't get it across, whether it's I can't pre-dilate it enough, I can't get it to go, guide extension, whatever. Those are the patients that we really need to know more about, because those are the ones that we still need combination therapy, right? There's no end around with that. And so I think that's going to be really helpful, because I think that's going to help us understand procedural success rates. Are they different, right? Because that's probably a more complex patient subset, right? Because I can't get anything to go. And then what are the MACE rates and the procedural success rates? And so I'm really, really excited to see those. Obviously, it's going to be a smaller proportion, still probably somewhat hypothesis generating, but I think really important when we look at our algorithmic sort of approach to how to treat these patients.
I might point out with that strategy that we know that burr size is a driver of complications in rotational atherectomy, and that there's no need with IVL to ever use a greater than 1.5 millimeter burr, period, to provide access. So I really think that that is another advantage where you're not going to go to 1.75, 2.0 burrs, things like that. You're not going to need to do that. It's hard to get deep calcium even with those burrs, frankly, because of wire bias. So I think this is a great 1-2 punch, if you will. A 1.25 or 1.5 burr followed by IVL. And that's, I'm hoping, don't know, but hoping that's going to be, the optimal combined strategy if we have to do it.
Yeah, until we start the Javelin study.
Yeah.
Stay tuned. Stay tuned.
Oh, I think that's important. Rob, you want to mention that? Because I think that's a very important adjunctive, potentially, therapy here.
Javelin is this really fun technology that, a lot of us over the years have, so IVL comes down the pipe, and it's really cool because it really takes away the need for all these other calcium modification technologies, because it's simple to use. You can use it right out of the box. There's no training curve, all this stuff. So then everybody kept thinking, well, what about the ones where I just can't get it in, right? So the initial sort of feedback was, well, great device, but somewhat hard to deliver. And then C2 Plus comes along, it's a little bit better. And then there's other iterations coming along. And then we learned how to use guide extensions and things like that to unsheath it. But there's still those lesions, just like we were talking about, where, despite all that, it's just not going to go. And that's going to vary in the hands of the user, right? Some people are going to be better at getting things in certain places. And that's going to be a constant regardless of education or anything else. And so really excited at the design change, where now we have a sort of an emitter right on the front end of the balloon that's going to sort of act to sort of inch itself through with those pulse generation and shock waves to be able to sort of take, just like we did with small balloons and CTOs and things like that, when our wire would be across and we couldn't get anything else to go. Same basic idea, bury it in the lesion, let the shock wave sort of create some cracks and then inch itself forward. And it's going to be really, really fun to see first how successful it is. There's been really fun initial data from our European colleagues showing that it works. And then it's going to be really fun to see, well, what happens when it crosses? What else do we need? How else does it work? And so we're really excited to get that going next year.
Rob, so people that are unfamiliar with this, would it be appropriate to say, analogize this to a microcatheter with a forward-facing single IVL emitter that you could gradually drive across blockage?
Yeah, absolutely. It's an RX. So the peripheral is going to be an over the wire. This is an RX, and it's very deliverable, handles very well, and exactly just like you said, forward facing, and it'll just be right there on the tip and just sort of inch its way forward as you emit. And so it'll be, we're not even sure how to use it yet. We're still figuring that out. Do you sort of lean it into the lesion? Do you just park it and then sort of gradually go? A lot of things left to learn, but I do think it has the potential to change the way we do PCI in terms of these more complex lesions. I think it has the possibility to really to really make treating these lesions much more homogeneous across skill sets, across types of places where people get treated, whether it's hospitals, ASCs, et cetera. And so I think it's going to really operationalize our ability to take care of complex patients in a variety of settings.
Fantastic. Any closing comments?
Well, I think it just adding on to what Robert said is that, you know, as we are expanding essentially our tool set and treating these patients who are becoming more and more complex, you know, we're expanding it not only for the entire population, but also for women, you know, that these patients, again, who are more likely to just be untreated because of the complexity of their disease, or the fact that there's concern about using, you know, atherectomy due to tortuosity or small vessels. You know, things like the javelin, you know, may really just open up access to so many more folks. And I think that that's an incredible thing that we're bringing into the field.
Excellent. Well, listen, I want to thank all of you, Robert, Margaret, Suzanne, for taking the time, making the effort to be here and provide all of this information in this conversation. And I want to thank SCAI for giving us this opportunity to really flesh out the details in some of these papers that are really important papers. I'd refer you to this paper that's published October in SCAI. So thank you for looking in, and we'll see you again soon.